Okay, so our next speaker is going to be Mariam Dadiani, who together with Dr. Day and Dr. Leah is representing the Eliava uh, Institute in Georgia, where she's actually been using bacteriophages in patients, and she's going to give us some of her insights now on that area. Thank you very much.
Hi, everyone. I'm Dr. Miriam from Eliava Phage Therapy Center. I'm accompanied by Dr. Leah and Dr. Dea. So we are representing internal medicine department at the EPTC. So I'm thankful, first of all, for the opportunity to be here. We were here last year, and we had a data analysis of EPTC. So it was a general data. So this time we want to talk about particular cases and particular patients. So I will go back to the title: Top Challenges: Respiratory and Urinary Tract Infections at the EPTC. So the patients that we have at the Eliava Phage Therapy Center are mostly urinary tract patients and respiratory system tract patients. As you can see on this slide here, there is a total samples data, and as you can see, sputum and urine and semen and EPS are the leading specimen that we isolate compared to the nasal swab, ear swab, mouth and throat swab, skin smear, etc. So this also represents the idea that usually patients that come to us are suffering from these kind of infections. Now to focus on particular ones, this is sputum culture data. And as you can see, we mostly see Pseudomonas aeruginosa, we mostly see Staph aureus and Streptococcus mitis. The first two bacteria are very common. They are infamous for their resistance, how severe infections they cause. As for the latter, Streptococcus mitis, it is usually part of the local flora, and we do not really consider it as a pathogen in the patients' cases that we see on a daily basis. As for the urinary tract and the culture data, here you can see the leading pathogens. There are lots of bacteria. There was a lots of the bacteria, but you can't really see the names of it. But the leading ones are E. coli, Enterococcus, and Klebsiella. So these are all of the bacteria that I've mentioned so far are part of the escape pathogens, and they are, well, biggest challenge nowadays with the antibiotic resistance. So that's why phage therapy is quite important in these kind of infections. So what happens when the patient comes to us? For us, it is very important to have the diagnosis, of course, but it's very important is to do the culture testing to isolate the bacteria and see phage susceptibility. Based on that, we perform in other investigations, other tests, devise a treatment plan, adjust the treatment plan, and treat the patient. So this is the scheme how it goes. As for the conditions itself from the respiratory system, we mostly see secondary bacterial infections during bronchiectasis, COPD, cystic fibrosis, primary ciliary dyskinesia. As for the urogenital tract, mostly we see chronic bacterial cystitis, chronic bacterial prostatitis, and chronic bacterial vaginitis. Now we will focus on the cases, but before that, as I've already mentioned, the bacteria that we see daily with this kind of patients, it's important to know which phages do we use. Of course, we use phages. We choose the most suitable phages based on the test, and usually, logically, with the urinary tract patients, we use phage that covers E. coli mostly, and we quite often have to prepare a custom phage, autophage for the Klebsiella. For the respiratory tract patients, we mostly use the bacteriophage cocktail that covers Pseudomonas aeruginosa. And of course, custom phages are quite common in these kind of cases as well. As for the phage administration methods, in these patients, as you can see with the pulmonary patients, patients take phages by mouth and via inhalation. As for the UTI patients, they take as well by mouth. Also, we use suppositories, vaginal and rectal suppositories, and sometimes intravesical administration of the phages as well. So now about the cases. So I will present 4 cases in total. Two will be UTI cases, chronic bacterial prostatitis cases, and 2 others will be respiratory tract cases. So why do we chose these cases? Usually because I said that mostly we see UTI patients. This is one typical, let's say, one typical patient at the Eliava Phage Therapy Center. And the approach that we have at the EPTC is that, of course, the attending doctor is urologist, of course, but our approach is that we, the internal medicine department, is fully invested in the patient, and all of the doctors work together to get the most desirable effect. So internal medicine doctors are heavily involved in the UTI patients as well. So regarding this patient, this was a 36-year-old male from the United States, and he was diagnosed with chronic bacterial prostatitis for 10 years. So this is a very important thing that I wanted to underline. We wanted to know, so why we chose this case. We wanted to know how phage therapy is effective when the infection has been going on for a long, long period of time. So this patient was officially diagnosed for 10 years. So his chief complaints were frequent urination, dribbling, hesitant urination, premature ejaculation, pelvic and lower back pain. So all of the years he was taking antibiotics by mouth, intravenously, all kinds of antibiotics. So, and initially he was feeling better on the antibiotics, but over the years, so the in-between period for the antibiotics really shortened. He became resistant. His complaints were not clearing up. So the last antibiotic that he used was ciprofloxacin for 4 to 6 years. So there was nothing else the doctors back in the States suggested to this patient. So over the 10 years, the pathogenic bacterium in his case was always Staphylococcus. So initially we tested this patient, and logically we also isolated Staphylococcus hemolyticus and Staphylococcus werneri in his different specimen. And unfortunately, they were resistant to our commercially available phages, so we had to prepare custom phages. So once the autophages. So once the autophages were ready, the patient has arrived on site at our clinic, and we started the therapy. So we started therapy, as I said, it was suppositories as well, but of course, it was oral intake of the phages as well. So the therapy lasted for a couple of months. Based on his symptoms, how he was responding, we adjusted the therapy. And after a couple of months, up to 3 months in total, approximately, the patient retested, and as you can see, the bacteria was fully cleared up, except for the Staphylococcus lugdunensis in the urine. We did not count this bacteria as a pathogenic one because while objectively the bacteria was fully gone, subjectively the patient was fully okay. His symptoms were all cleared up. So at this point, we stopped all the therapy, and we, in a couple of months after, actually this year, this patient also just retested for the sake of it, and his samples still keep testing negative. So the patient, after 10 years of these complaints of this antibiotic therapy, after a couple of months of phage therapy, the patient was fully cleared with bacteriophage therapy. So the second case is of similar nature in terms of it refers to the chronic bacterial prostatitis, but this is compared to the previous case. This patient was suffering from this infection for 2 years approximately. So that's why we choose these two cases. One refers to the long-term therapy, but this is more short-term infection. So this patient was 66-year-old male, and he was also from the United States. So his complaints were dysuria, frequency, urgency, malodorous urine, and importantly, it's very important to know that he also had high fever and extreme fatigue during acute infection episodes. Also, he was taking antibiotics non-stop. So when the patient came to our clinic, he was on Bactrim for a long period of time, and he couldn't really stop this antibiotic intake. And the pathogen that was always tested in his samples was E. coli. And as you can see, there was tons of antibiotics that were used in his case. So what happened with this patient? Of course, we started with the sample testing. We saw E. coli, and the therapy lasted a bit longer than with the previous patient, because as you can see on the graph, there was E. coli. We prepared a custom phage for the E. coli. At some point, Enterococcus faecalis came up as well. So his bacteria was changing over the time. We were adjusting the therapy. We used broad-spectrum phages. We used custom phage. We used suppositories, or he was drinking the phages. And gradually, tapered the antibiotic. So he was not taking antibiotics slowly. And so first step was he successfully switched from the full-time antibiotic intake to full-time phage intake. And gradually over this period of time, he also cleared up of all the symptoms that he had. And right now he's symptoms free absolutely, and he's not taking phages as well anymore. So up to this point, both of these patients are totally healed after these long infections. They are not taking phages anymore. They keep testing to see what's going on, because one is subjective improvement and other thing is objectively what the lab says. So in both of the cases, we have full effect in terms of the objective markers and in terms of subjective improvement of the patients. So this is why so I wanted to underline that in this kind of cases, this is actually getting published, and you can see the details online as well. What we wanted to say with these UTI patients, for us, the internal medicine team, what we found a correlation is that with this kind of patients, we also test stool sample, because gut dysbiosis is heavily linked to the infections in the urogenital tract. So this is something that we see so far, but we are trying to analyze this and see what other patterns and dynamic we can see in these patients. So with the UTI patients, we also test stool quite heavily. So this sums up the UTI patients. Now we will go to the respiratory tract infection. So this case is also submitted for the publication. This case refers to 56-year-old male from France. He was diagnosed with cystic fibrosis in his early childhood, because it's diagnosed very early in the beginning of the life. And unfortunately, these kind of patients do not live long. And when this patient addressed us, it was over 10 years ago. He was 43, and since that day, he's alive and well. He's a patient of Dr. Leah for this period of time. And so since the age of 10, he had Pseudomonas aeruginosa infection, and he was taking intravenous antibiotics, and he could not, his quality of life was very, very bad, and he was on a list of lung transplantation. So at France, they couldn't really suggest anything else, but he tried to see what he else could do, and found phage therapy on the internet, because his quality of life was very, very bad. The productive cough, shortness of breath, fever, everything. So it was really affecting his life. So it was Pseudomonas aeruginosa that was mostly found in his samples, but also Staph aureus, we isolated that bacteria as well. So susceptibility to the phages were quite changing. So several times we had to adjust the therapy. So I want to underline the fact that we are not treating cystic fibrosis. So we are treating secondary bacterial infections that happen in this kind of condition, because this predisposes to the infection. So this therapy is not a short-term therapy for this kind of patients. They have to take phages for quite a long time. So what we saw with the results. So the approach that we had with this patient was quite different, quite new. We didn't really have a patient that was undergoing phage therapy for such a long period of time. So we had custom phages, broad-spectrum phage cocktails. He was taking inhalation. He was taken by mouth phages, doing inhalations, etc., etc. And the findings, the results that we got that are very important, is that he did not use antibiotics that he was heavily relying on since the year of 2017. And he didn't really have any acute exacerbation or didn't need hospitalization since 2017. And of course, well, the symptom improvement meant less coughing, no episodes of shortness of breath, decreased sputum production. But most importantly, and this is something that we doctors see on the analysis, but we heavily rely on the microbiologists, and we also want to get answers from you. We think that for the past 2 years, Pseudomonas aeruginosa has been fully eradicated. That is a statement that we can't really, you don't really hear often in this kind of patients, because Pseudomonas aeruginosa is very, very hard to eradicate in this particular patient. So far we see that there is no Pseudomonas aeruginosa in the test, but unfortunately Staph aureus keeps persisting, and we manage his infection so far. So his treatment plan was very, very individual, as is with other patients as well, but this is very particular patient. One thing that is very noteworthy, he was taken out of lung transplant list from the France because they didn't see the need to give him another set of lungs. They could not actually explain in France why this happened. Of course, we know why, but they could not really say that it happened because of phages. So that's so this patient became, after 10 years, he became a not only patient but a dear friend. He lives in, well, part-time lives in Georgia as well. So this next case and last case for today refers to the male, 50-year-old male that suffered from diagnosis is bronchiectasis. Since the early ages, he had frequent bouts of pneumonia that caused his bronchiectasis. So his chief complaints were chronic productive cough, dyspnea, and recurrent pneumonias. So it's similar to the previous patient. There was Pseudomonas aeruginosa that was getting tested again and again, and he was, of course, getting antibiotics since the age of very early childhood. And so he wanted to see what else he could do, similar to the previous patient. So what is different here? So his Pseudomonas aeruginosa became resistant. We started therapy with broad-spectrum phages again, custom phages, but what happened with this patient is that he frequently got resistance to the custom phage. So this slide, I think, is more familiar to you rather than it is to me. This is what our microbiologist shared with me. So why? So I hope there is a PFGE picture that shows that compares the strains of Pseudomonas aeruginosa, and our microbiologists see that there is a particular change that probably there's a mutation that probably resulted in the resistance of the custom phages. But well, the good thing with the phage therapy is as long as we see the bacteria, we can prepare a custom phage again and again. So this patient as well continues phage therapy till this day, but not as extremely as the previous patient. He has very in between period for exacerbations is very long. So he resides in Japan, and the doctors from Japan are quite actively collaborating with us, and we're both very happy with the findings. So he visited us last month actually, and his CT scan was very 3 minutes, yeah. So his CT scan was quite good. The bronchiectasis, there was no new bronchoectasia areas. But one thing, I will go back to the previous slide. So one thing that was weird is that at our lab, he tested for Pseudomonas aeruginosa, but in Japan, they saw Pseudomonas putida. We were not able to isolate the bacteria somehow, but in Japan, they saw these bacteria. So we keep testing these patients, but we don't really see this bacteria anymore. So this is the scheme of the treatment plan, and it's also different from the usual. It's very individual, and it's inhalation and by mouth intake as well. I think this sums up all the cases that I have so far. Me and the rest of the team will like this kind of conference where there are lots of scientists and microbiologists, because I'm sure you have questions to doctors, but we have tons of questions to microbiologists, and we will try to reach out and see what kind of questions we can get you and what kind of answers we can get, because we know as long as we do not harm, based on our experience, 100-year experience, we treat the patients. But in phage therapy, it's like there are tons of questions, so hopefully we can do something together and find all the solutions and answers. And I think that, yeah, that wraps it up. Thank you. Oh.
Yeah, thank you very much, Mariam. It shows the difficulties of working at the front end and that incredible specificity. So are there questions for Mariam, or questions from Mariam to the audience?
Very interesting talk. I'm puzzled by the diversity of bacteria that you have. The first patient, you have 3 different species of staph, and the last patient, you have 3 different species of Pseudomonas. So here I didn't see the details. So these are different phages you use to treat the 3.
So we prepared for his 2 strains. We prepared 2 custom phages.
Okay.
Custom phage is similar to autophage. And we've prepared these ones, and he underwent therapy with these 2 autophages. Right here you can see.
Yeah, it's puzzling that the same patient has three strain over 10 years.
Sorry?
I'm puzzled that the patient has three different strains, species of
Actually,
stuff over.
we see in our patients, those most of our patients who have like decade-long infections, their culture report is very, very interesting because it's all different, but it's all always multibacterial. Of course, there's one leading pathogen, but it's quite often for us to see the different strains.
Yeah, that's good. And your phage at the end on the Pseudomonas, does it work also on Putida, on Pseudomonas Putida and fluorescence or not?
You mean the custom phage that we
Yeah,
prepared?
like for example, yes.
Well, the autophage is particular for one strain, so it was only for aeruginosa. That was the only strain that we isolated at our lab.
Okay.
So we could not really
Okay.
address Pseudomonas putida.
Okay. Thank you. Very nice talk.
Thank you very much. I was wondering, can you comment on the routes of administration that you're giving these by?
Mhm.
So in some cases, you're giving it by, for lungs, you're giving
Mhm.
it by inhalation and orally. Do you know if one is more effective than the other, that you really need both?
Mhm.
Or similarly, a little bit more unusually, you're using rectal and
Mhm.
orally for a UTI.
Mhm.
Do we know that you need both routes of administration? Is one preferable than the other, for example?
So that is very interesting question. That is something that we work on and very thoroughly think about it. So we have different routes of administration depending on where the infection is located, but the main route of administration remains to be by mouth, so oral intake, and the additional routes are dependent on where the infection is. So we have inhalations, we have ointments, we have suppositories, there is nebulization, intravesical, but we decide on spot based on how the patient is feeling, what his symptoms are, what would be the best way. For example, the why suppositories, right? Because there is always a chance, let's say for bacterial vaginitis, chance for the retrograde infection. So we are working locally for the vaginal flora to prevent the upstream infection, if I'm saying this word correctly. So also the patients, male patients who are suffering from the UTIs, in their experience, they found that actually the local suppositories, due to the anatomical proximity, they give them instant relief, the suppositories. So based on that, we use the other ways of administering, but by mouth intake is the one that we heavily rely on.
Okay, and just for when you're giving it by mouth, do we have a good understanding of how the phages are getting from the GI tract through to, say, for example, the lungs or the UTI?
Good understanding? No, that is one question we also. Oh, I think I. That is the question ourselves, we doctors have to the patient, not to patients, but to the researchers and microbiologists. What we have is our experience, and what the doctors tell us is that, well, not the doctors, what our experience says is that the amount of phages that we are giving the patient eventually leads to the resolution of the symptoms. So we know that well, there is a gut barrier, the acidity, we try to tackle that as well. But the amount of phages that eventually with the long-term therapy, of course, the phages go wherever the infection is located, and eventually they help. So somehow they go there. But that would be the answer I would really like to hear from you.
All right, thank you.